So let's continue with another lecture. And it will be on the role of the 3D echo in aortic and tricuspid valve disease. Of course, the mitral is the most important because the best image quality can be achieved. And I will not speak about the pulmonary valve disease because it's difficult to visualize with 3D echo. So according to the guidelines, right now, let's use 3D in mitral valve disease, especially in case of stenosis. This is the recommendation according to the guidelines. It might be useful in the assessment of aortic valve disease, and it is still in the research area in other fields. However, the daily practice is different. For example, in case of aortic valve disease, we love to use 3D echo because it can show this complex three-dimensional structure of the aortic root. This anatomical region, which is the virtual basal ring, is one of the most important region because we measure accurately this ring for the selection of transcatheter heart valves. Nice images can be obtained with transthoracic 3D echocardiography from the parasternal window or even from the apical window. And both the aortic side or the ventricular surface of the aortic valve can be visualized. This is a nice 3D transesophageal image of the three cusps aortic valve, and we can rotate and look at the ventricular surface and the coaptation lines from the opposite direction. Of course, we always start with the biplane imaging with color, and then we turn on with full volume with color, and at the end we focus on the valve with 3D zoomed images. When we would like to analyze the valve, we go off cart, and with multiplanar reconstruction with QLab, we can properly align the two-dimensional cut planes into anatomical orientation. According my orientation, I always align the blue cut plane in the long axis of the LVOT and ascending aorta, and then with I-slice, we can define the narrowest portion of the orifice. Some vendors provide aortic valve models. We don't have it with Philips, but this is, for example, a Siemens model, which is quite accurate and tells us also about the dynamicity of the aortic root. So how to use 3D echocardiography in aortic valve diseases? It helps us in the morphological and geometrical assessment of the root and the cusps. It can provide some special parameters like intercommissural diameter and the zone of the coaptation or the effective height of the leaflets, and helps us to define the distance between the annular plane and the coronary ostia. So we will have better assessment in aortic valve stenosis with lower interobserver variability, and the three-dimensional area measurement of the outflow tract can be implemented into the continuity equation to better define valve area or to select the proper prosthesis size in STAVI. Of course, the stroke volume quantification will be more accurate if we use this LVOT 3D area measurements. In case of aortic regurg, the pathomechanism can be defined, and again, for quantification purposes, we use the vena contracta area measurement of the regurgitant jet, and we can define whether the valve is suitable for repair or transcatheter aortic valve implantation. I just would like to show you some pathologies. This is a Sievers type 1 bicuspid aortic valve, the most common form when the left and the right cusps are fused with a little bit calcified roughness, so it easily can be seen that we have just one coaptation line, so it's easy to repair that type of valve. And on this image, for example, in the transverse plane, we could measure the length of the coaptation of the cusps. This is the quadricuspid aortic valve, again with a central regurgitant jet and with 4 cusps. And of course, with 3D, it's easy to define from which coronary sinus do the coronary arteries originate from, which is an important information before surgery. We do know that the aortic root is not circular. It is ellipsoid again. That's why the normal quantification of the aortic valve area from 2D echo is inaccurate. The 2D echo always measure from parasternal window or from long axis TOE this short diameter. But it's not circular. We have a long diameter of the root. So the final result should be multiplied by 1.2 to have the true area of the LVOT and the valve area. So we always overestimate the severity of aortic stenosis with 2D. I used to correct my final result with this 0.2 number. How to measure the root and the diameters and the geometry of the root? We align properly anatomically, and then just with a perpendicular plane, we define in which level we would like to measure something. For example, if we stop at the tip of the cusps, we can perform 3D guided planimetry, which is more accurate than 2D measurement. And in case of we are interested in LVOT, we stop just here, go deeper, and stop at the it doesn't show this animation, and stop deeper and measure the LVOT. Here you are. Okay, so now you just go further. This is a simple method. Before TAVI, we use the double oblique technique, which is more complex, which resembles to CT method, but I don't want to get you scared of complex methods right now. So LVOT measurement will help us in aortic stenosis, valve area quantification, stroke volume, shunt calculation, or before septal myectomy in case of hypertrophic cardiomyopathy, and before TAVI. The 3D guided LV diameter should be used, and the area in the continuity equation, and the true valve orifice area by planimetry when it is 3D guided. But if we go further, we can further analyze the aortic root and measure the height of the cusps in open position, the diameters of the root on different levels, the intercommissural distances, and the length of the coaptation. It should be at least 4 millimeters after valve repair to be able to be competent. How to do this? How do we analyze the coaptations? First, we will do it in the afternoon if you are interested in it. First, we get the 3D image into anatomical orientation. Then we rotate the image to get the aortic valve orientation, and then with I-slice technique, this is what we get first, the aortic orientation, and then the corresponding 2D images will be nicely oriented, always. So we are 100% will be sure which cusp is which cusp, even in case of bicuspid aortic valve. And then what to do? We select one coaptation line, put the I-slice parallel cut planes, and analyze this coaptation from the central portion till the commissural point. Here are the corresponding images. So on each slide, I can define whether there is a prolapse, how long is the coaptation zone, what is the main pathology resulting in regurgitation. This subtle analysis of the coaptations is quite important before valve repair. So if you send a patient to aortic valve repair, you have to present those loops for the surgeon. What about the subvalvular stenosis? This is a nice case when you can see that below the valve there is a membrane, and with the help of 3D, I performed a multiplanar reconstruction. You can see that right now the cut plane, the blue cut plane, just properly cuts through the subvalvular membrane, so it was easy to measure with planimetry the true subvalvular stenosis, and it was like 0.3 square centimeter, so close to the significance. The coronary ostia are visible with 2D and with 3D, but it's only with 3D that you can define the distance of the coronary ostia from the annular plane. And if you use a Corvalve type prosthesis for TAVI, then we have to know this distance, because otherwise you can cover the left main and cause severe infarction during valve implantation. This is aortic stenosis, we already mentioned it. And what about aortic regurgitation? This is a nicely remodeled ventricle with what we very often see, that the jet, the regurgitant jet, is very, very eccentric and very much difficult to analyze with 2D echo. So in that case, I enlarged and zoomed down the valve, but it was not 100% easy to define what is the main pathology. So I acquired 3D color loops. You can see that this jet originates from posterior superior position going anteriorly, and with multiplanar reconstruction it was nicely visible that this jet is a consequence of a severe prolapse of the non-coronary cusp. So in that case, the pathomechanism was, according to the El-Khoury classification, El-Khoury 2A. So it's a very detailed analysis and need to have some experience, but not too difficult to learn it. When we would like to quantify the severity of regurgitation, we again go for vena contracta area. So we align with the jet, and just in the perpendicular plane we measure the smallest region, which is the vena contracta. In infective endocarditis, I would not say that 3D helps a lot. It might help because we can look at the valve from the bottom, from the ventricular surface, and the attachment of the vegetation is mainly on the ventricular surface of the valve. So it can help us to define which cusp is affected. But usually the vegetation itself is a highly mobile, soft tissue, and sometimes it can be overlooked. But with the help of 3D, we can image the mitral in the same pyramidal data set. And in this case, you can see the kissing vegetation. So this mobile aortic vegetation, when it touches the anterior leaflet, may stand the infective disorder, and there was a perforation, and on the atrial side of the leaflet already a new kissing vegetation appeared on the mitral valve. Which are the limitations of 3D? Again, the resolution, and when we have to acquire multi-bit images, there will be stitch artifacts, and dropout is a problem in case of aortic valve because cusps might have a very thin structure. So at the very end, we just a little bit discussed the right atrium and the tricuspid valve, but in around 60% of the cases, the patient might be suitable to visualize the tricuspid valve, but very often we cannot analyze with the 3D because of the poor image quality. When we have two-dimensional images, sometimes we are sure which leaflets are visible, for example in the apical fourth chamber, but in parasternal short axis and parasternal inflow view, it depends on the cut plane, and we are never ever 100% sure which leaflet can be visualized with that cutting plane. So the 2D echo have got a lot of limitations. And again, we try to define the annulus size with 2D, which is very, very inaccurate, and the leaflet analysis is inaccurate. So let's start with 3D. We come from the forevalve view and rotate the data set from the atrial aspect to the ventricular aspect of the valve. And then with cutting techniques, and that was a transthoracic data set, with proper cropping and rotation of the data set, we can have an atrial view and a ventricular view of the valve. So this is the method I did. As you can see, this is right now, this is the image quality, which is sometimes suitable, sometimes not enough. However, the final result will be more accurate with the help of three-dimensional echocardiography. But if we would like to have the feasibility, we see that in different parameters, only the half of the patient is feasible to 3D analysis. We would like to also know the pathomechanism of tricuspid regurg. Those are the most common forms of tricuspid regurg. This is a normal valve and the ventricular perspective. This is how the tricuspid looks like in case of pulmonary hypertension. Very often 3D helps in case of pacemaker lead interference, because with the 3D we see whether the pacemaker lead is in the commissure where it should be or not in the commissure, and it might restrict mainly the motion of the posterior leaflet and the septal leaflet. And this is a rheumatic valve disease with commissural fusion. Again, endocarditis and vegetations might be visible, and with the same method, completely the same method, we can accurately measure the stenosis, the valve orifice area, and the vena contracta of the regurgitation. This is not very often that we can have a nice overview of the prolapse. This is a posterior leaflet prolapse, but hopefully in the future we're gonna have better transducers with better image quality. The most important additional value of 3D echo is the annular size measurements. We do note that the functional mitral tricuspid regurg is very common, and it is a result of not only the annulus enlargement and dilatation, but also the tethering of the leaflets. If just the annulus is dilated, there is no tricuspid regurg. But if the annulus is dilated and there is a tenting of the leaflets, so the entire geometry, annular and subvalvular geometry, is diseased then or distorted, then you're gonna have a functional tricuspid regurg. So with 3D, we measure the true annular diameters, short axis and long axis, and we also can discover the saddle shape of the tricuspid annulus, but we still don't have model of the valve. For quantification of severity, we again use a similar method, vena contracta measurement with multiplanar reconstruction, and it can be classified as severe if this vena contracta area exceeds 0.7 square centimeter. Of course, the three-dimensional assessment of right ventricle would be important. Philips Aptona can't provide this software, but this is a TomTech software analysis, which we also use in my institution in Budapest. Limitations are quite similar in the detection of the disorders. And I hope with the improvement of probe and transducer technology, we will get more and more information on the tricuspid valve as well. Thank you for your attention.